We had another Hilo question, I think, before. Yeah, go ahead, Hilo.
That person who just asked the question said there was another question, or someone else in your team or in your group. Do you have another question, Hilo? Can you please state your name and your question? Okay, we're going to open to the other islands. You see, it's a requirement that they do ask questions in order to get CEUs. So we'll open the...
So the coordinator of the site, please make sure if you got anyone that really wants a CEU, they're welcome to attend, but if they want us to send a CEU, somebody needs to participate verbally. Please use the opportunity now because we have very little time. Otherwise, we're going to go for anyone here at the Queens. But I know there's so many people on webinar and VTC sites right now.
Anyone else out there? Kauai? Maui? Big Island? Any more questions?
As they get ready, why don't we take another question here? You had
Good
a question?
idea.
Also, if your mics are muted by the state telehealth system, please call them and tell them to unmute you, because we can't tell. Nobody's saying anything. We know we got through the Hilo, but we're not sure about the other side since no one's saying anything.
I had a few issues. When I lived over in Kailua Kona on the Big Island, the OBGYNs over there, this was a few years back, were just leaving the island in droves. And one of the things they complained about was the cost of insurance, and the other thing they complained about were having to deliver a baby to a patient that they had never met, and the cost of that care and being responsible on their insurance if anything went wrong. That's the first thing. Another is, have there been any changes to the insurance?
Let me address that. I'll
Okay.
just in one by one so I don't forget. Okay, so OBGYNs have been leaving because, yes, their malpractice is higher than almost any other malpractice because they're a surgical discipline and a medical discipline, and they're a procedure discipline, so there tends to be some extra reimbursement. But it was disastrous, one or two bad cases, and they're going to happen. You know, knock on wood, they don't happen often, but there are cases where since you don't know your patient, you don't know that they had a larger baby or that their mom was doing drugs or that their kid just had a problem in prenatal, or they had no prenatal care is another problem. So a lot of them left. Now, the way we've been reversing that is actually we've been hiring physicians. Ali'i Health is founded now, and it's in affiliation with Kona Hospital, and Ali'i Health provides specialists, including, I believe, a few OBGYNs. And so this is a movement that we're seeing. It's another part of the bigger milieu of the Health Care Act, the Affordable Health Care Act, which is we might see a lot more employed physicians and fewer private physicians that have independence. And I don't think that that's a great solution, but it is what could very well happen, and we're seeing here in Hawaii already. And then, of course,
so were there any changes to the insurance rates, or with this legislation that's happened, have there been any changes to that insurance?
Had their medical malpractice insurance been lower, it's very possible they would have stayed. But that takes a fairly long time to have an impact, and I'll be frank, it is unlikely in general that bill will pass in Hawaii, in general. I will tell you a little vignette, and that's that at the national level, when they were negotiating the Affordable Care Act, there was a deal on the table before it passed in 2010 in March, and the deal was this: let's come together and have agreement, a much larger majority rather than just all the Democrats voting for it and none of the Republicans voting for it, just squeezing it through. The deal was the Republicans were going to float the amendment to have medical malpractice reform, and the Democrats were going to, who in general oppose it, were going to swallow hard and accept that in exchange for a much broader public option, which was that was the baby of the left part of the Democratic Party, to have a bigger public option.
Or expanding Medicare.
Right. And so, yeah, or Medicare for all. I don't want to get into that debate right now, but the point I'm trying to make is that both parties would have compromised, and we'd had some malpractice reform and a broader public option. And what I'm told is that it became clear to Republicans that it was simply the bill in general was too anathema to them because of the mandate and so on. So they didn't want to engage at that level and make that deal. So when they walked away from the deal, medical malpractice reform fell out of the bigger bill, and lots of other compromises were made, and this is what we got. But that was an opportunity probably to get medical malpractice reform, but it's not my place to say what a U.S. Senator should do. Do we have another question from the...
Gentleman over here has the mic.
Another question over here?
Yeah, do you know what a grand aid is?
A what?
Grand aid.
A grand aid?
Yeah.
I don't know that term.
It's something they started in the third world. It's been incorporated by primary care into the 1115I that's going to go in. The object there is a triage list of 30 questions and an iPad that the notion was anything, half of all office visits could be eliminated if you went to see a knowledgeable grandmother.
Oh, I get you.
So this is just a list. It's like the community health workers, and the idea is to stop people from going to the doctor, and that's going to directly affect whether people retire, what's going to happen to the hospital rooms.
So you bring up a good point, and whatever it's called, whatever term one uses, conceptually, it's going to be very difficult for us to train a whole new expanded workforce of healthcare providers quickly, and it would be ideal to not just do a superficial fix to the healthcare system, because we're not going to come back to this for a while. So if we can muster up the courage to do a lot more preventive medicine and a lot more health literacy, it probably is a good solution, and I do think there should be some resources applied to that. So if a doctor or a nurse hires that person in their office or in the community, they're paid for it, and then they can make a good educated decision on when someone really needs to come in, because it's not a perfect system, and a lot of times there really is just nothing better than a quick physical exam, even if it's very short, from any healthcare provider that's been trained clinically. But I support something like that.
Anyone else have a question?
Valerie has one.
I always hear about increased costs because all these people will have, insurance and access to the medical care, but I think it's disingenuous to say it's only increases, because there's no talk about the savings from people hopefully getting better care and staying out of the ER and staying out of the hospital. And because these people are receiving care anyway, they just keep going back and forth to the hospital, like those 50 people that are going to now be served by that new program that the state of Hawaii is piloting to take, do community visits for the frequent flyers that spend all their time in the ERs.
Let me address that concern, which is good. It's a good observation that, look, we do know that system-wide approaches to problems can move mountains. There are successes. It can happen. So the low-hanging fruit, okay, unnecessary emergency room visits. 20% of the healthcare system, 20% of HMSA's dollars are spent on that every year, over $400 million on unnecessary ER visits. That money could definitely be spent by them, and they agree, better on prevention and access to outpatient care and what have you. And it makes a lot of sense to do that. Also, long-term investment. I'm not overly concerned about spending more money on healthcare, provided we spend it right. So that we spend it intelligently, because there's a lot of things that we can do better. For instance, we can have fewer sick days at work. We can have more productivity, actually. You can have, we are in a relatively closed economy here, okay? So whether you spend 18 or 20 or 25% of your dollars on healthcare and healthcare workers, or you spend it on those in the, in the tourism industry, these are still jobs, okay? And so we just have to decide what we're going to prioritize. There are some fundamentals that you have to prioritize in a society, and that tends to be basic education, basic health care, and public safety questions. fire and police, okay? Beyond that, sky's the limit. You can decide. You can hire people and invest in roads, which are expensive, if people want them, or you can invest in hospitals and physicians and nurses, if the people want them. It becomes an economic choice, but that money will tend to stay here. So I tend to think that even if we spend more, it's better spent on health and human services. A broader example might be spending money on early childhood education, okay? It turns out that if you actually want to spend money in any society, that's where you want to spend it, because you get a 7-to-1 return on your money. Everyone knows this. Far fewer people end up in prison. Many more people end up getting out of high school and not needing Medicaid or welfare assistance if you give them early education, which makes everything else easier to pay for, and it's just plain good for people because it's a good experience, it's good for the parents to be able to work and so on. But it's a paradigm shift because you don't see the immediate gains. And I think that same logic can be applied to putting in good systems of health care where people don't need to go to the hospital, they don't need to end up on 6 medications, they only need maybe 2 medications. They don't need to retire from work at 63 or 64 because they're incapacitated. We can use their experience until they're 68 because they want to work. So it becomes a fundamental question of how you prioritize your country's budget. It's an interesting question, probably, in fact, certainly far above my pay grade, but I would say in general, we should be spending more money on educating people so that they can become healthcare workers and become outreach individuals, and we should be spending a lot less money on end-stage renal disease, prison cells, and just clean up for severe drug and alcohol addiction problems that are very, very hard to treat. So I think we're going to probably have to wrap up this question, but if we really do decide as a society that we're going to prioritize these things, we're very likely, per your statement, to come out a lot better. But anyway, thank you for having me. I really appreciate it. I know we're at the end of our time, but anytime you want to get in touch with me, please call me directly. It's my pleasure to talk.
I'd like to thank everybody for being here. Hope you'll come back next month. Our topic next month will be HIV and AIDS. Thank you very much, Senator, Doctor. Excellent training and update on all that's going on now with the Affordable Health Care.
Please remember next month we will have food starting at 11:30 and something we never have, which is actual validated parking for either the hospital or POB1.
I'm going to give you my...
It doesn't work for POB3. So the speaker is bringing some resources with her to make sure she's got a great audience and you can hear a really dynamic speech. Thank you. On HIV and AIDS.